My name is Leanne Bricker. I'm a consultant in fetal and maternal medicine, and I'm the chair of fetal medicine and the medical imaging department at Corniche Hospital. So fetal medicine is a relatively new discipline in medicine where the fetus is in fact the patient. But obviously we look after the pregnant woman as well. But our prime patient is the fetus. In some cases where there's a problem with the baby, or actually in a twin pregnancy, we can provide, in some conditions, we can provide treatment while the baby is still in the womb, and that is what we call fetal therapy. Fetal therapy is only done in very rare and few cases, and therefore there are not many centres in the world providing this. Usually in most countries there'll be 1 or 2 centres, and then other fetal medicine doctors and teams will refer patients to that centre for fetal therapy. One of the commonest procedures we do is fetal blood transfusion, so giving a baby blood while it is still in the womb. And this happens in cases where the baby is anemic and has a very low blood count. If the baby is not treated while in the womb, it will go into heart failure and die. And the most common reason for a baby being anemic in the womb is if the mother has unusual antibodies that attack the baby's red blood cells when she is pregnant. We will monitor the fetus regularly for signs of anemia, and the way we do that is we measure blood flow in the baby's brain. And if the blood flow in the baby's brain is very fast, and we have charts that we can chart the velocity of the blood flow, we know that if the speed of the blood flow is above a certain threshold, that the baby is probably anemic and needs a blood transfusion. It can happen at any stage in pregnancy. With each pregnancy, it happens earlier and it's worse. The best way to save that baby is to give it blood while it is still in the womb. We give the blood and then we keep monitoring, and 2 to 3 weeks later we sometimes have to give more blood. And we give blood every 3 to 4 weeks until it's time to deliver the baby. Another procedure we do, less commonly because it's required less commonly, is shunts. So a shunt is basically a tube, a hollow tube that we can either put into the baby's bladder or into the baby's chest cavity to drain fluid. We put it in the chest if the baby has got a pleural effusion, which is a large collection of fluid in the chest that is pushing the heart and the lungs over to one side. We put a tube into the baby's chest and it comes out into the amniotic cavity in the fluid surrounding the baby, and the fluid can drain, and then the pregnancy can continue, and when the baby is born, the problem that is causing the fluid can be treated definitively. The other time we use shunts is if the baby's got a bladder obstruction. And most people don't know this, but babies are actually surrounded by their own urine and floating in their own urine. It is very important that baby has fluid around it, first to protect it, but it's also very important for the baby's lung development. Babies have to breathe in the fluid for their lungs to develop, and if a baby has no fluid around it, it will not develop normal lungs and it will not be able to breathe after it's born, even with the best treatment and with advanced care in a neonatal unit. We put a tube into the baby's bladder, coming out into the amniotic fluid. This creates fluid around the baby that wasn't there before, which is important for baby's lung development. But it also takes the pressure off the kidneys, because the bladder being full and blocked causes back pressure on the kidneys and can cause kidney damage, so it takes the pressure off the kidneys. When patients are referred for fetal therapy, it's very important that they are referred to a centre who are doing a significant number of cases and are competent. Because these conditions are rare and these procedures are rare, they really should be focused in a few centres so that the doctors working in those centres are doing them regularly and maintaining their ability and their competence to do those procedures. It's also very important to realise that not many doctors do the training to be able to do these procedures because they're very rare. And you need very advanced skills and expertise in ultrasound scan and in doing invasive procedures in the womb to be able to treat these babies.